Welcome to Nevada Week. I'm Amber Renee Dixon. According to the state's Ending the HIV Epidemic Plan, Nevada has the highest rate of new HIV infections in the western United States. Additionally, the CDC estimates that only 41% of Nevada's population has ever been tested for HIV. Joining us with perspective on those statistics and on this year's theme for World AIDS Day are Antioco Carrillo, Executive Director at Aid for AIDS of Nevada, or AFAN, and Dr. Roseanne Suge, a physician with UMC's Wellness Center. Thank you so much, both of you, for joining us on this important topic. Dr. Suge, in a conversation that we had off camera, you stressed the importance of differentiating between HIV and AIDS, and that's where I want to start. Why is that important?
So it's really important because I still get patients who come to me when they're first diagnosed and they're talking about, oh, I have AIDS and I'm going to die. And it's different. So HIV is actually the virus that somebody acquires, and it doesn't necessarily mean that you have AIDS. So AIDS is what happens when the HIV virus starts to attack the person's immune cells. And when the immune cells of a person drops low enough, they're not strong enough to fight off other infections and other conditions. And that's when you get AIDS, or acquired immune deficiency syndrome.
And the danger in someone coming to you and saying, I have AIDS, when they simply have HIV at that point and they think it's an automatic death sentence. What is the danger in that?
The danger is anxiety, depression, all kinds of mental health issues that are seen specifically because their life changes automatically. Many years ago, in the 1990s, I used to be the crisis manager for the testing center, where anybody was tested positive. They used to send them to us because I used to do therapy, and it was all about, I have AIDS. This is a catastrophe. My life is over, and it was only a diagnosis. It was only they were exposed to the virus, a year before or 6 months before, and you were able to manage all of that. But the perception has always been, this is the end. I'm diagnosed with HIV, and now I have to look at all those movies that we used to have, like Philadelphia, and I'm gonna be in a wheelchair, and that was what was happening in their mind. And still, in a lot of people, still that's a possibility. And then the other thing is guilt and shame, because I did something wrong. I brought this on myself. And as we know, that's part of understanding and adapting into the newer reality until everything is addressed.
It is no longer a death sentence. The CDC reports that in 2020, Nevada's HIV diagnosis rate was the 5th highest in the country. Why is Nevada ranking so high? Dr. Suge?
Okay, so we have to recognize the syndemic of other sexually transmitted infections. To add to your statistics, Nevada's #1 for syphilis. We're in the 22, 23 for gonorrhea and chlamydia. And so, all those sexually transmitted infections, you get one, it's a little bit easier to acquire a different infection. And we know that social determinants of health push some of that. We've seen it as well with COVID, where we know that education, homelessness, poverty, lower income levels all contribute to higher risk for acquiring these infections.
And those are all present in Nevada. Anything you would add to that as to why Nevada is so high?
Well, specifically, I think there is a little bit of stigma, and people still reluctant to get tested. They find that there is stigmatization in all the senses. It doesn't apply to me. My behavior is my behavior. It doesn't apply to me because I'm not gay, or because I'm not a drug user, or because I'm not, some of that also still keeps people from getting tested. To me, I think that that's part of the challenge that we see, is that people are not thinking of getting tested, when it's important, like for the rest of individuals. It should be like, getting tested should be like
getting a colonoscopy or a mammogram.
Exactly.
It's standard screening. It's actually a USPSTF standard screening to screen everybody for HIV at least once in their lifetime, from 15 onwards.
So why is it not happening in Nevada like it is in other states?
It's the stigma.
Yeah.
I mean, I don't know. In terms of pregnancy, it took us a while to get pregnant women to kind of get tested, right?
Yes.
And to pass the regulations and all those things. because of the stigma. People don't perceive themselves to be at risk.
Right. I mean, we've done focus groups on this, and it's patients don't see that they're at risk, and then there's this added layer of, I don't want to find out I have AIDS because, again, the whole difference between HIV and AIDS, but this fear that you're going to give me a diagnosis and I'm going to die and I don't really want to know about it. So
it's best if I don't know.
It's best if I don't know, yeah.
So then the education, is that not the same in Nevada as it is in other states? Or I'm still trying to figure out why Nevada.
Why Nevada?
Yeah.
So if you look to ending the HIV epidemic, the federal government actually targeted 48 counties where more than 50% of new HIV infections are found every year, right? So Clark County is one of those counties that they targeted. But what you see is most of them are actually kind of in the southern states as well. And education does matter. So the highest risk populations and the highest groups of new infections are young adults. And so if they don't know what their risks are, they're not going to do anything to mitigate those risks.
I teach at the university, and I teach undergrad. And I asked individuals about the risk factors, and inevitably, every single one of the students has had a risk factor over the last 6 months. And they don't see what we saw, and they don't see the challenges that we used to have before we had the medication. So they don't think about that. And I asked them about, what the risk factors are, unprotected sex, and all those things. And they're like, And we're talking about people in their 20s.
Right. I mean, they've said, when I've talked to students, it's like, is that even still a thing, HIV?
Yes.
Really?
Yes.
Yeah.
You brought up the medication. How well understood do you think it is that there is medication to prevent HIV?
Well, it's not well known outside the community that has been affected. We're talking about PrEP, pre-exposure prophylaxis, right?
Right.
And we're talking about ensuring that people that are not HIV positive take the pills to reduce the risk. But we're not talking about allowing people to behave the way they're going to behave, because they're going to behave the way they want to behave. It doesn't matter. We're talking about ensuring that people have the option and different layers of protection in their own lives. And the challenge that we have in the community at large is that if you're not HIV positive and you start taking those pills, that means you're doing something, dirty. That means you're engaging in some behaviors that maybe you shouldn't. And in a matter for public health, we believe that that's just increasing the layer of safety
Right.
that anybody can have.
Definitely. There's no downside to offering all various options for prevention, right? So I kind of liken this to birth control pills or birth control, right? There's different methods of contraception. Some it's don't have sex at all, and for some it's get a depot shot. And so in HIV with PrEP, we also have those tools, right? And in fact, now we even have a long-acting injectable treatment for PrEP that just came out,
Yes.
which just increases options for patients.
Yeah, and it's the stigma.
Well, the
Yeah.
stigma that if you're taking it, you're doing something wrong.
Absolutely, and we know. And I had, I in the past I've had board members that when we talk about that, it's like, wow, we don't want to talk about that. And it's, well, that's a matter of public health.
Yep.
And it's like, what about, you're giving them a license to do other things? No. And then I give them examples of zero discordant clients and couples that we have. Well, one is HIV positive, one is HIV negative, and you want to be able to make sure that both of them are protected. On top of using, condoms and protection, that the other layer of protection is the medication, where in the event of an accident, then the other person is not at risk of getting HIV.
I have a friend who takes PrEP, and he has insurance, thankfully. If he were not to have insurance, would he be able to afford this?
Yes. So the federal government actually has something called Ready, Set, PrEP, which navigates patients to have access to medication. They just need to be able to ask for it.
How do you go about doing that?
You can ask any.
And you get it for free.
Yes,
Yes.
you get access to it, and you get it for free. You can, if you want it, it's available to you. Our challenge as providers is that
Having
not
patients
right.
ask or having the providers offer it to the
Right.
patients who need it. So that's the other piece.
Right. Why is it not being prescribed at the rate it should be?
Because this is recently a new phenomenon, right? Recently, we're talking over the last few years, And we always feel that we are behind the times with the rest of the country for whatever reason, because there's not a lot of providers, there's all kinds of things. But we do know that if we had the opportunity right now to end the epidemic, we could do it if everybody that it has a level of risk of being infected begins to understand what PrEP is and how that can change his or her life. We can do this. We can end the epidemic as we do it now, right?
Right. And on the other end of that spectrum, if people who are living with HIV actually get tested and identify that they have HIV early, we can get them on treatment, which improves their health outcomes. But also now we have this concept of U equals U, undetectable is untransmittable. So we know that patients who are virally suppressed cannot transmit their virus, with or without condoms, to their partners.
Wow.
So that's the added prevention layer.
The theme for this year's World AIDS Day is, quote, putting ourselves to the test, achieving equity to end HIV. So it's encouraging people to globally unite and eliminate the disparities and inequities that create barriers to HIV testing, prevention, and access to care. What inequities, if any, exist here in Nevada when it comes to HIV? Antioco.
Well, there's always a constant assessment of the services we provide with our community partners, with their funders, and it's always about trying to ensure that we reduce any barrier, whether it is an office that is open 9 to 5 and people are not able to access services because that's when they work, and modifying things like that, whether it's having information in other languages other than English, in Spanish, in Tagalog, and other languages. That we are an international city, so we have clients that speak almost any or every language that you can possibly imagine, and ensuring that the information gets to the communities that really need it, the African American community, the Hispanic community, and ensuring that they have access to not only the information but also services in their communities. And I think that we have not been able to achieve that, which is the opportunity that we have as we move forward.
Right, and so we know that there are disproportionate share populations who are affected with HIV. 12% of our general population in Nevada are Black, and yet almost 40% of new HIV infections are in that population. And so again, this is increasing access points, improving education, and again, all those social determinants of health. We know they matter. We know that income levels and poverty levels and things like that will impact patients' health and
their access to care.
And their access to care. So we're fortunate we're in an expanded Medicaid state, so that certainly helps, but having health care coverage does not equate to having access to providers. Nevada's doing what it can. We are now testing at all our quick cares, so patients just need to ask for the test or schedule an appointment for HIV screening, and it's a point of care test. You'll have an answer in a minute.
Will you tell me that again? Health care coverage does not mean, what did you say?
Access to care. So just because I have Medicaid doesn't mean I'm going to get to see that doctor in a day, right? So
why?
Because of scheduling conflicts, because of lack of transportation, because of
Nevada, we're number 48 for physician to resident ratio. So the number of providers we have versus the number of people we have in our population, we're number 48 in the US.
Will you talk about the Latino population being affected by HIV in Nevada? How prevalent is that?
It is. I think the percentages is around in the 30%, right?
Yeah, it's about 25-30%. So it's still a little, again, disproportionate share. Still a little bit higher than the general population for Latinx.
And obviously, is mistrust to past, government, imposing or finding their status about immigration or anything like that. It is a variety of reasons. But the other one that I find always the more common is the lack of, information in Spanish for the community in general. We still get people that come and they still think that HIV does not affect them because this is a disease that affects only Americans, white people, not the Hispanics. It doesn't affect us. Yeah, there's still that stigma, especially immigrants. And so a lot of information in Spanish that should be just blasted out into the community, that is part of what we're looking at. And unfortunately, the prevention messages or the prevention methodologies changed, and the idea of sending HIV prevention messages as we used to do it in the 90s, it doesn't happen. It's just now prevention is about treatment. It's about medication.
Correct.
Right?
I want to make sure we touch on the stats from 2020. The CDC says to exercise caution when you're looking at them because of what COVID did to access to testing and care and services. What did you notice? How did COVID impact HIV in Nevada?
So definitely we had to close down testing in a lot of places in the community. And you're going to see the stats in Nevada. We're usually at about, on average, 450 new cases of HIV a year, more than one a day, right? And you will see that drop in 2020 where we were under 400 cases. And that's, I wish I could say it was because we did a whole lot of good in terms of prevention and treatment, but I think it's because people weren't testing. You don't test, you don't find it.
Yet Nevada was still 5th in the country in 2020.
Yes.
And the risk factors still there. They
So-
were still there. And let's not forget a lot of what we see in the clients that we have and the low socioeconomic status that where they are. You know, people that are on the verge of being homeless, people that are having problems with the crisis that we have right now in terms of housing. You know, we get clients that come to the office and they don't have an address, so we can't reach them. And you know, our focus has always been to get clients into the system and to ensure that they stay within the system, that they don't fall out of care. And that was particularly challenging over the last 2 years when we faced a lot of the challenge of the COVID, right? Because we couldn't track them. They were not able to come in. And if we offer services online or however we did it, they don't have a phone. They don't have a way to just do what we want.
Or
so those
even
are
a private space to talk. So
Yeah.
we offered telemedicine when COVID hit, and it was still, I don't have a private space to talk. And again, the stigma layers into it where, you know, they don't want to disclose their status to whoever else is at home. And so there are all these challenges.
How much
around
of a
treatment.
step back did we take in terms of HIV progress because of COVID?
I don't want to make predictions, but I do know that we really have to catch up over the next couple of years.
Yeah.
We really need to start working a little harder to ensure that we were at the pace that we were before COVID.
Correct.
Correct. Okay. We talked about men who have sex with other men being the population that is most affected by HIV, but there is another demographic that is being impacted, and that is African American women. Why?
So again, disproportionate share population, even in the men who have sex with men, black men are also very high on that list. Like I said, 12% of the population versus 40% of new infections. And so when you think about communities you trust and the social networks people have, that is where some of that transmission occurs, right? So
We need more providers that are
Yeah.
African American.
So there's that trust in the community.
That they can trust. And unfortunately, we're not able to just, you know, all of a sudden just, you know, have contracts for people that can open clinics in places with the population of African Americans and Hispanics. You know, I still get nightmare scenarios from Hispanic clinics where they don't know what to do with HIV. All of a sudden they get tested
Right.
and somebody's positive. It's like, okay, I
They're
don't know
getting
what
the
to do
phone
with
calls
it.
to help.
Yeah, I don't know what to do. Just need to go to the health district because I don't know what to do with it. And these are, you know, professionals. So there's a lot of work that still needs to be done with providers, acquiring providers, ensuring that providers reflect the population that they serve. And that has always been a challenge.
Right. So, I mean, there's historically a lot of medical mistrust in terms of the populations and people of color. And it's not unwarranted, right? You have
No.
Tuskegee, and that's like, that was in the 40s and 50s where they had syphilis experiments in Alabama on African American men.
Right.
So it's not unwarranted that there is that medical mistrust. And certainly having people who are like you as your providers helps. So we just need more providers in Vegas.
Yeah.
There is a new needle exchange program at the Southern Nevada Health District that recently opened, providing sterile syringe kits in hopes of reducing the transmission of hepatitis C and HIV. The health district acknowledges, yes, these are going to be used to inject illegal drugs. For that reason, there's a federal ban on funds for the purchase of needles for this purpose. But what do you think about that idea that this is just promoting bad behavior?
So it's not, right? So again, this is that paradigm shift even in medicine where we talk about harm reduction and risk reduction. It's incremental steps. People jaywalk all the time, right? I don't know if you've ever jaywalked. And it's, they might not stop doing that, but you talk about wearing a white shirt or wearing something neon, looking left and right before you do it. And it's the same thing. It's giving patients a toolbox. If they're not ready to stop using drugs, and sometimes it's not a choice. Substance abuse is a complex issue, right? You give them the tools necessary to stay safe, right? Let's not have skin infections. Let's not spread HIV or acquire HIV or hepatitis C, which we see more with needle exchange. Same thing with PrEP.
I have to stop you there. We have run out of time, but thank you both so much.